Okay, so let's pick up where we left off then. So we were looking at the cingulate gyrus here. So, and I'll just move on now to look at it on a coronal image. So this here is the cingulate sulcus, and adjacent is the cingulate gyrus. So I'd say in the exam, if you were going to get asked, it would either be in a coronal or a sagittal plane. I don't think it would be likely to be on the axial plane. So if you just have a look here again, so we've got the corpus callosum and the cingulate gyrus just sitting superior. And again, this is the coronal. So this is the cingulate sulcus and the cingulate gyrus. And I'll just point out, this is the choroid plexus we can see in the ventricles, and this is the cerebellar hemispheres. So again, we're now moving more inferiorly, and we can still see the frontal lobe in red and the parietal lobe in blue. And we can start to appreciate the temporal lobe in yellow and the occipital lobe here coming in green. So we're now at the level of the basal ganglia structures. So what is the basal ganglia? So it's a group of grey matter nuclei in the deep aspects of the brain that are interconnected with the cerebral cortex, thalami, and brainstem. So in a strict anatomical sense, the basal ganglia contain three paired nuclei. So the caudate nucleus, and this here in the brown is the head of the caudate nucleus. The lentiform nucleus, which is here, and medially we have the globus pallidus, and laterally we have the putamen. And then this structure here is the thalamus in the sort of light purple. And as Dr. Khan already highlighted, this is the anterior limb of the internal capsule, the genu, which is knee in Latin, so the bend, and then the posterior limb of the internal capsule. This is the external capsule, and this is the sylvian fissure here. We can see it pointed out on this side. And just immediately deep to the sylvian fissure is the insular strip. So this insular strip, as you may already be aware, is very important in early detection of middle cerebral artery infarction. And we're going to look at an example of that in the following slide. So I'll just let you have a look at this CT brain. So on the right, this is the sylvian fissure. And just as we said, immediately deep to it, we can make out the hyperdense, the bright insular ribbon area. But on the other side, if you compare the region immediately deep on this side and immediately deep on this side, you start to appreciate that this is a lower, we've lost the bright insular ribbon sign. And this is due to early sort of ischemic changes and edema. So this can be a very subtle early sign of MCA stroke. And this is the same patient 24 hours later, just to demonstrate how extensive this stroke has now become. So it's very important to review this as an early area of stroke on a CT brain in the appropriate clinical setting. And it's important to change the image to stroke windows, which helps you pick up these findings easier. So we're now just going to look on again at the basal ganglia structures, and this is slides more for revision purposes. So we have the head of the caudate nucleus, the lentiform nucleus, so the putamen and the globus pallidus. The thalami lie in here. So internal capsule, external capsule, insular strip, and sylvian fissure. And I'm now just going to briefly mention, this is the genu of the corpus callosum and the splenium of the corpus callosum. So the corpus callosum, I mean, it really could be asked in a sagittal image, but there's no reason why this, for example, or this part of the corpus callosum couldn't be asked on the axial image. So we previously mentioned the sylvian fissure. So just to show you this again, and it separates the frontal lobe from the temporal lobe. And as mentioned in the previous slide, the insular cortex lies immediately deep to the sylvian fissure. And this is it on the coronal image, which again could easily be asked, and a sagittal, or sorry, an axial MRI image. And this is just to highlight the sylvian fissure on a sagittal image. So we're now going to look at the corpus callosum. So this is the rostrum, the genu, the body, and the splenium. So what is the corpus callosum? So it's the largest of the commissural fibers in the brain. So commissural fibers are axons that connect the two hemispheres of the brain. So it connects the cerebral cortex of the left and right cerebral hemispheres, and it's the largest white matter tract in the brain. It can be also, as we've said, divided into rostrum, genu, which again means knee or bend, body, and splenium. We're now going to have a look at the pineal gland. So this is this pine cone shaped structure here, and it just lies inferior to the splenium of the corpus callosum. And this region here is what we call the tectal plate. So this is part of the midbrain of the brainstem, the tectal plate. And this small structure here is the pineal gland. And as Dr. Khan had already mentioned, particularly in adults, we can see it often as a midline calcified structure. So the pineal gland is clinically relevant. So this is a sagittal T1 post-contrast weighted imaging showing a mass in the region of the pineal gland. And in this case, it is a pineal germinoma. So it is compressing the tectal plate. And subsequently, there's CSF, which flows between the third ventricle here and the fourth ventricle here through the cerebral aqueduct. This mass is compressing this route or this flow of CSF and is causing upstream obstructive hydrocephalus. Not only that, the mass is compressing on what we call the superior colliculi, which is the superior aspect of the tectal plate, which is responsible for visual reflexes. And this gives a upward gaze palsy, and it is known as Parnod syndrome or the setting sun sign. We're now going to have a look at the occipital lobe. So this is a parasagittal image showing the occipital lobe here, and this is the parieto-occipital suture. So we have the parietal lobe, occipital lobe, and the parieto-occipital suture. So within the occipital lobe itself, we have the calcarine fissure, and between the calcarine fissure and the parieto-occipital fissure is the wedge-shaped structure called the cuneus. So this sort of wedge-shaped triangular structure here. Now we're going to have a look at the temporal lobe. So we can see we have the superior temporal gyrus, middle temporal gyrus, and inferior temporal gyrus. And in turn, these are separated by the superior temporal sulcus and the inferior temporal sulcus. And this is the Sylvian fissure here. So we can look at this in this parasagittal MRI image. So superior, middle, and inferior temporal gyrus. So I'm now going to have a look at the temporal lobe on a coronal MRI image. So again, we can make note of the superior temporal gyrus, the middle, and the inferior. And a very important structure in the temporal lobe is the hippocampus, which is this region here. So it's an important component of the human brain situated in the temporal lobe, and it plays a very important role in information processing, the reproductive cycle, and it is also involved in Alzheimer's disease and temporal lobe epilepsy. So if this is the hippocampus, this is known as the parohippocampal gyrus. So para meaning beside, parahippocampal gyrus. And this is the collateral sulcus. So hippocampus and parahippocampal gyrus. So this is a coronal image again through a similar level, just to reinforce these learning points. And I'll just let you have a quick look at this. So this is sort of the hippocampal region, parahippocampal gyrus, collateral sulcus, superior, middle, and inferior temporal gyrus. And as we talked about previously, this is the cingulate sulcus and the cingulate gyrus. And here, this is the corpus callosum and the head of the caudate nucleus. And these are our Sylvian fissures and the insular strip. So we're now moving into the brainstem and the cerebellum. So the brainstem is the most inferior part of the brain, and it is structurally continuous with the spinal cord. So it consists of the midbrain, the pons, and the medulla, which is the component that's continuous with the cord. So the brainstem provides the main motor and sensory innervation to the face and neck via the cranial nerves. It also plays an important role in the regulation of the cardiac and respiratory function, and it also regulates the central nervous system and is pivotal in maintaining consciousness. So in this image on the left, we can see the Mickey Mouse or the midbrain, and these are the cerebral peduncles, which connect the midbrain to the thalamus. And this, we talked about the tactile plate. Well, this is the most posterior part of the midbrain. And then we're moving more inferiorly into the pons, and then more inferiorly again into the medulla oblongata. So now I'm going to look at the midbrain on this sagittal MRI image. So we discussed the midbrain, the pons, and the medulla oblongata. And Dr. Khan, has previously mentioned the mammillary bodies on an axial image. So this is the mammillary bodies, this circular structure here, just anterior to the midbrain. And this is the tactile plate, superior and inferior colliculi. And this is what we talked about, the third ventricle flowing down into the fourth ventricle through the cerebral aqueduct, and masses in the region of the pineal gland can put pressure and obstruct this flow of CSF. We have the rostrum, the genu, and the body, and the splenium, the corpus callosum. This is the cingulate gyrus. And in this image, we can also appreciate the cerebellar hemispheres coming into play here. And because we're central here, this is the cerebellar vermis. So Dr. Khan talked about the clivus. And then this is the sella turcica, or the Turkish saddle, in which the pituitary sits in. So I'll just mention it as it's on this image. So this is a T1 weighted sequence. So we can see the anterior pituitary here, and this is the posterior pituitary. And you'll note that the posterior pituitary is bright, and this is the normal bright spot in T1 of the posterior pituitary. This is a normal appearance. This is the pituitary stalk, or the infundibulum, joining up to the hypothalamus. And then anteriorly, we have the optic chiasm. So we'd previously mentioned that the midbrain connects to the thalami anteriorly, but posteriorly we have three connections of the brainstem to the cerebellum. So we have the superior cerebellar peduncles, the middle cerebellar peduncles, and the inferior cerebellar peduncles. So realistically on your exam, if you're going to be asked this, it's most likely going to be the middle cerebellar peduncles, because the superior and inferior ones can be quite difficult to detect on MRI imaging. So I would really focus on the middle cerebellar peduncles, which connect the brainstem to the cerebellum. So particularly the pons to the cerebellum. And then just to mention, this is the midbrain. So these are the cerebral peduncles anteriorly, which connect up to the thalamus. And here we can see the mammillary bodies, as previously noted. And this is the interpeduncular cistern here. So we've already mentioned the tactile plate, but just to mention it in a bit more detail. So this is the midbrain, and we can see the tactile plate is at the posterior aspect of the midbrain, and it's responsible for auditory and visual reflexes. So the tectum houses 4 rounded prominences named colliculi. So we have 2 superior colliculi and 2 inferior colliculi, which sit directly inferior to the pineal gland. So as we've said, masses in the region of the tectum or pineal gland can cause mass effect on the tactile plate and cause pressure on the superior colliculi, resulting in paranoid syndrome, but can also obstruct this flow of CSF, causing hydrocephalus. Just check our time. I think we're doing okay. Okay. So we're now moving on to look at the brain stem in a bit more detail and some of the cranial nerves. So these are diagrammatic illustrations of the brain stem and cranial nerves. So as you know, there's 12 cranial nerves in total. The olfactory nerve and the optic nerve originate from the cerebrum, but cranial nerves 3 to 12 arise from the brain stem. And the cranial nerves are numbered by their location on the brain stem, going from superior to inferior. Some of the cranial nerves can be very difficult to visualize on standard MRI sequences, and thin slice, high resolution special sequences on a 3T scanner are often required. Even with these special sequences, some of the cranial nerves are small and are still difficult to appreciate. So from a point of view of the exam, I'd say the most important cranial nerves to learn would be the 5th, the 7th, and the 8th. That's the trigeminal, the facial, and the vestibulocochlear. So I'm briefly going to show you some high resolution images of the cranial nerves, but Dr. Khan will provide some further detail on this in the next session. So we're at the level of the midbrain, and here we can visualize the 3rd cranial nerve, which is the ocular motor nerve, and the 4th cranial nerve here we can see coming out, which is the trochlear nerve, and it's arising posteriorly out of the midbrain. So ocular motor nerve, so midbrain, the Mickey Mouse shaped midbrain, ocular motor 3rd nerve, and then trochlear nerve coming out more posteriorly, and it's a smaller nerve. So we're now moving towards the level of the pons, and cranial nerves 5 to 8 arise out of the pons. So this is the 5th cranial nerve, or the trigeminal nerve, and it could potentially be asked on the exam. So you can see we're at the level of the pons, and this is the trigeminal 5th cranial nerve. So we're now still at the level of the pons, and we can appreciate cranial nerve 6, the abducens nerve, in these circles. And as we can see, it is quite a small, sort of not as prominent nerve as the trigeminal nerve. And we're now on to image G, and we can make out the facial nerve, 7th cranial nerve anteriorly, and the vestibulocochlear nerve posteriorly, and these are running in the internal auditory meatus. And I think it could be reasonable enough that they could be asked on your exam. So we're now at the level of the medulla oblongata, so we've moved more inferiorly, and cranial nerves 9 to 12 arise at this level. So in this image, sorry, I think there's just a bit of writing on the screen. I'm not sure if anybody else can see that.
You have to stop. Oh, I think whoever was doing it has realized, so please continue. Okay. Otherwise, you have to take that right from everybody, but please continue.
Okay. Okay, so in this image now, we're looking at the 9th cranial nerve. That's a glossopharyngeal nerve. And as we said, it exits the medulla and courses anterolaterally, you just see it here, towards the pars nervosa of the jugular foramen. And in this image, we can appreciate both the glossopharyngeal nerve, which is number 9, and the vagus nerve, which is cranial nerve number 10, which is just here. And I mean, these are high resolution images, and even at that, they're still quite small and difficult to make out. So the circles here are pointing out the accessory nerves, which are cranial nerves 11. And finally, we can see the hypoglossal nerve here at the level of the medulla oblongata, and that's cranial nerve 12. So I'm now going to move on to discuss the cerebellum. So the cerebellum is Latin for little brain, and it is found at the posterior and inferior part of the brain. So it has many functions, including playing a vital role in maintaining balance, coordinating voluntary muscle movement, and executing motor control. So the cerebellum has 2 hemispheres which are connected centrally by the vermis. There are 3 anatomical lobes that can be distinguished. So we have the anterior lobe, the posterior lobe, and the follicular nodular lobe. And these lobes are divided by 2 fissures, the primary fissure and the posterolateral fissure. So we're now going to look at some axial images through the cerebellum. And there's a bit of repetition here with regards to the brainstem structures and their connections to the cerebellum. This will also help consolidate the learning. So we're at the level of the pons here. And we can also make out the fourth ventricle. So this is the vermis centrally, and we're quite superior here in the cerebellum. And then we're just starting to make out the left and right cerebellar hemispheres, but this is the superior aspect. And as I've said, the vermis is central. So we've come slightly more inferior, and now we can appreciate, this is the middle cerebellar peduncles, which connect the pons to the cerebellum. And again, as I said, we can visualize the fourth ventricle here. And now we're starting to appreciate the left and right cerebellar hemispheres. And now we're at the level of the medulla oblongata. Here. We can appreciate the folliculus, which is this number 1. These are the cerebellar tonsils. This is the vermis centrally. And then we have the cerebellar hemispheres. So just to mention the cerebellar tonsils, because they are clinically relevant. So they are bilateral ovoid structures located in infero-anterior part of the cerebellar hemispheres. So this image on the left is a sagittal T1 image to demonstrate the normal position of the cerebellar tonsils. The image on the right demonstrates tonsillar herniation. So, i.e. downward displacement of the cerebellar tonsils through the foramen magnum. And this is also referred to as coning. So we see this when the tonsils descend into the limited space of the foramen magnum, which is in this region here. The brainstem and adjacent arteries are compressed, which will result in death without emergency treatment. So in this particular case, the cerebellar tonsillar herniation was due to a cardiac arrest, hypoxic ischemic injury, which subsequently resulted in diffuse brain edema and swelling. And this is what pushed the tonsils downwards into the foramen magnum. So we're now going to go on and discuss the ventricular system. So as you know, the ventricular system is composed of CSF-filled ventricles and their connecting foramina. So the CSF is produced by ependymal cells which line the ventricles and also the choroid plexus. So CSF is the clear liquid that surrounds and bathes the brain and spinal cord, and it has numerous functions. So it protects the brain and cord against rapid acceleration and deceleration forces. It provides buoyancy to the brain, maintains the intracranial pressure, supplies nutrients, and removes metabolites. So we're going to have a look at the flow of CSF throughout the ventricular system. So it flows from the lateral ventricles through the foramen of Monro into the third ventricle. Then we come down through the cerebral aqueduct into the fourth ventricle. And then we come through the Magendie and the foramen of Magendie and the foramen of Luschka. And CSF then flows around the brain and spinal cord from this location. So the majority of CSF is reabsorbed into the venous system by the arachnoid villi, which protrude into the dural venous system around the brain, particularly that in the superior sagittal sinus and transverse sinuses. So we're now going to look at this flow of CSF on an MRI image. So this first image really is to just show you the choroid plexus here, which lies in the atrium of the lateral ventricles. So these are the lateral ventricles. And then we're coming down into the foramen of Monro, which are these tiny slit-like foramina here. We move down into the third ventricle, through the cerebral aqueduct. It's here. So third ventricle into the cerebral aqueduct, into the fourth ventricle, So this is the fourth ventricle here, and we're central, sagittally and sagittal image, and we're central. This is the foramen of Magendie, and I try to remember it with M for Magendie and M for midline. And then this coronal image, this is the foramen of Luschka, which are L for Luschka and L for lateral, and Magendie centrally. So just while we're here, we'll just summarize that again. So the third ventricle, through the foramen, the cerebral aqueduct, into the fourth ventricle, and through the foramen of Magendie. So this is the cerebellum. This is our tectal plate, our superior and inferior colliculi, pineal gland, midbrain, mammillary body, pons, and into the medulla. So just to look at some pathology then. So this is a non-contrast axial CT brain image. So we can visualize there's a large mass here located centrally within the posterior fossa. So I don't know if you can appreciate, but it's slightly hyperdense in CT. And this points towards the possibility of it being a medulloblastoma. And this is a 6-year-old child. So as a result of mass effect and complete effacement of the fourth ventricle, there's significant obstructive hydrocephalus. So the ventricular system is much larger than it should be for a 6-year-old. And we can also start to appreciate this hazy low attenuation here, adjacent to the ventricular system. So this is transepidermal edema, and it is a radiological sign of acute hydrocephalus. A CSF is forced out of the ventricular system into the surrounding brain parenchyma. So it's just demonstrating really that if there's any pathology in the brain and it obstructs the normal flow of CSF, it can result in acute hydrocephalus, which likely in this case would need decompression and a shunt placed. We'll now move on to look at the basal cisterns on MRI. So the basal cisterns are compartments within the subarachnoid space where the pia mater and the arachnoid membrane are not in close approximation, and CSF forms pools or cisterns. So again, similar to the ventricular system, as they are interconnected, their patency is essential for CSF circulation. Furthermore, cisterns may have vessels or cranial nerves passing through them. So again, they're clinically relevant, and mass effect for any reason and increased intracranial pressure can efface one or more of the cisterns. And when a patient has a subdural hemorrhage, blood can fill the subarachnoid cisterns. So in this example on the right, this demonstrates a very extensive subarachnoid hemorrhage, and this is the hung chicken sign. Blood can fill these subarachnoid spaces and block the flow of CSF, resulting in obstructive hydrocephalus. And we can just appreciate that the temporal horns may be becoming slightly prominent here, and this can be one of the early subtle signs of developing hydrocephalus. So this is the same table as Dr. Khan had in his presentation. So there are a lot of cisterns, but really from a point of view of the exam and from a point of view of your day-to-day practice, the ones highlighted in pink are the ones we're going to have a quick look at now. So first to look at the suprasellar cistern. So if we think of its name, supra and sellar, so the pituitary, this is the sellar region. So it makes sense that the suprasellar cistern would be just superior to this region. And this is the sella again, just to show you on this radiograph. So the Turkish saddle, we have the pituitary sitting in here, and the suprasellar cistern is just superior here. So this axial CT scan through the midbrain again shows the suprasellar cistern with a stellate or star-shaped anteriorly, enclosing the vessels of the circle of Willis. Posteriorly, the suprasellar cistern fuses with the interpeduncular cistern, which is here. This is the midbrain, the Mickey Mouse midbrain, and the interpeduncular cistern. So we can visualize the interpeduncular cistern, the ambient cistern flowing around the side, And then the quadrigeminal cistern lies here posteriorly. So it's highlighted here, nice star shape, interpeduncular cistern, ambient cisterns flowing gently around the side and then into the quadrigeminal plate cistern. So these cisterns are grouped together, known as the perimesencephalic cisterns. So it's just to show you one more image to reinforce it. So suprasellar region, so suprasellar cistern, interpeduncular, ambient, and quadrigeminal. And you could be asked this on a CT or an MRI study. And this is our interpeduncular cistern between the cerebral peduncles of the midbrain. The mammillary bodies are again here. And this is coming into the vermis of the cerebellum. Here we've just highlighted again the ambient cistern. So we'll now move on to look at the prepontine and the cerebellopontine cistern. So the prepontine cistern lies anterior and around the pons. And we can visualize the basilar artery running through this cistern. So this is the prepontine region here. The cerebellopontine cistern is located between the anterior cerebellum, which is here, and the lateral pons. So this is the cerebellopontine cistern, also known as a cerebellar pontine angle. And as we pointed out previously, this is the internal auditory meatus, and the facial nerve runs anterior, and the vestibulocochlear 8th cranial nerve runs posterior. So just to look at our cisternal anatomy on a sagittal image. So we can appreciate this is the so we're smack in the midline here, and this is the midbrain. So this is the interpeduncular cistern. This is the pons, so this is the prepontine cistern, and we can appreciate the basilar artery running here. And this is the medulla here, so this is the premedullary cistern. This is the quadrigeminal cistern. And now we can see the cisterna magna. And this is really the same anatomy on a sagittal MRI image. So again, pituitary region, suprasellar cistern in here, region of the 3rd ventricle, cerebral aqueduct into the 4th ventricle, formative megendae, cisterna magna, pineal gland, tectal plate, corpus callosum, anterior and posterior pituitary, infundibulum up into the hypothalamus, and the optic chiasm. So we're getting near the end of the talk now. So we're just going to have another look at sella, pituitary region, and cavernous sinus. And I'll just check our time to see how we're doing. Okay, that's fine. So just another 5 minutes approximately. So in this sagittal MRI image, we can again make out the anterior and the posterior pituitary. And we talked about the posterior pituitary bright spot in T1. We have our stalk or infundibulum, and then we have the hypothalamus and the optic chiasm. So I'm just going to let you have a quick look at this, because I feel like we've repeated this quite a few times already. And it's just some further, I mean, and definitely this could be asked in the exam. Any of this anatomy could really be, you know, pointed out, and you'd be expected to sort of know what sort of these key areas are. So I'll just let you have a look at this. And so we talked about our midbrain connecting anteriorly by the cerebral peduncles up to the thalamus, although we can't fully appreciate it in this image. I'm just going to move on now. So this is a axial image, and this is the pituitary stalk here. We have the optic chiasm, and then we can see the optic nerves here, which traverse through the optic canal. Again, optic chiasm, pituitary stalk, and optic nerves traversing through the optic canal. So the cavernous sinus, just we're in the region of the pituitary here, I'm going to mention the cavernous sinus. So unlike other dural venous sinuses, it is divided by a number of septa, fiber septa, into a series of small caves, which basically is where its name is derived from. So the normal lateral wall, which is here and here, should be either straight or concave, i.e. inward sloping. If this wall is bulging out, it suggests there's pathology in this region. So the following cranial nerves traverse the cavernous sinus within the lateral aspect of the wall here. So we've got ocular motor nerve, cranial nerve 3, cranial nerve 4, V1 division of the cranial nerve 5, trigeminal nerve, and V2 division. And then the only nerve which actually lies within the cavernous sinus itself is the abducens nerve, and it's very small and difficult to visualize in MRI. And this is the internal carotid artery, which also traverses the cavernous sinus. So just to look at this imaging on an MRI study, I think it could be quite tricky to ask you this on an exam, but certainly it could point to the cavernous sinus or it could point to the internal carotid artery. And this is the pituitary lying centrally here, the infundibulum, and the optic chiasm. So you could probably get the pituitary on coronal or sagittal plane imaging as a question. So this brings the MRI neuroanatomy session to an end. So in summary, we have covered the lobes, the fissures, and the gyri. We've looked at the brainstem and the cranial nerves. We've also had a look at the cerebellum. We moved on to look at the CSF spaces and the flow of CSF through the ventricles. We've looked at the key important cisterns, and then we briefly covered the sella, pituitary, and cavernous sinus region. So I appreciate it's probably quite a lot to take in, but I hope when you go to do your private study, it will have been helpful and you'll start to become familiar with these terms, especially with the repetition during this session. So thank you very much for your time, and I'll pass you back over to Dr. Khan.
Okay, thank you very much, Donna. That was brilliant. So I will move on. So in the beginning, I told you that we are going to repeat. Now, I am going to build on everything which has been taught till now, and it will be a repetition. It will consolidate things, and I will go to the next step also at places. So with this, we'll go quickly. Most of this is going to be images, but a few things which are not covered, I will cover now. So as far as the ventricle is concerned, the diagram is in front of your eyes. You already know this, but what I want to add is something. Now, this is the frontal horn, the body, the atrium, the occipital horn, the temporal horn. Now the CSF comes into the third ventricle. Third ventricle is an area of interest in neuroimaging. And in the midline sagittal, there is a lot of action happening. Now, this is the anterior wall of the third ventricle. This is the posterior. Now, develop your eyes on this thing. There is a recess which goes into the infundibulum, this thing here. This is known as infundibular recess, and this can be seen on special sequences. This is chiasmatic recess. These are the two anterior recesses. Posteriorly, there is a pineal recess which goes into the pineal gland, and there is a suprapineal recess. And of course, rest of the anatomy, you know it. And so in this region, pineal region is extremely important. So I will add to whatever has already been covered. Now, this is the pineal gland. Now, inferiorly, you can imagine that the third ventricle from here to here is the third ventricle, right? And it's a midline slit. So this is the anterior wall of the third ventricle. And there is a membrane there which is known as lamina terminalis, this thing here. and this goes all the way to the optic chiasma, superiorly to the rostrum. Now, there are commissure fibers here. This is the anterior commissure here. This is the posterior commissure, and on imaging, actually, we can see these two things. There is a midline structure, which is a dead structure because no messages are going through it. This is the massa intermedia of the thalamus, but there is a connection there. Now, concentrate on the pineal gland. Superior to the pineal is another commissure, which is the habenular commissure. So, inferior to the pineal is the posterior commissure. Habenular commissure is superior to that. Now, come to the brainstem. So please remember, we are at the midline of the brainstem. So from here to here is what we call the tegmentum, and this is the tactile plate. And if we go parasagittal, then you will see the superior colliculus and inferior colliculus, which are a paired structure, but they will be right and left. This is a midline sequence. Now concentrate on the relevant cisterns here. Now, posterior to the midbrain is the quadrigeminal cistern. So, posterior to the pineal gland, all of this area is quadrigeminal cistern. Here is cerebellum. Superior to that is the superior cerebellar cistern. There is a fancy name which is coming. So, in this region is what we call cistern of velum interpositum, and this is where the internal cerebral vein they pass. This is an internal cerebral vein. This thing is an internal cerebral vein. Right and left, they join together to form the vein of Galen. This is the vein of Galen. Vein of Galen, internal cerebral veins. These are to be veins, and I will show you a few examples if I've got time. So this part of anatomy, though covered, but I will cover it again vis-a-vis the things which I have showed you. So this was the anterior commissure. You see this thing, anterior commissure, pineal gland. So this has to be somewhere here is the posterior commissure. And look at this vein. This is the internal cerebral vein, and this is the vein of Galen. So this structure from here to here is the floor of the third ventricle. Extremely important for exam and for day-to-day radiology. And you can see that this is a highly T2-weighted sequence in which you can see the optic chiasma. You can see the infundibulum of the pituitary. You can see CSF going in. So this is the infundibular recess, this thing. And here, this is the optic recess of the third ventricle. From here till here is the hypothalamus. And the names which should be in your vocabulary include tuber cinereum. You don't have to remember, but please remember there is a tumor, hematoma of tuber cinereum, which is an exam case, and you have to remember where is tuber cinereum. It is this floor of the third ventricle. And this is, anterior perforated substance, which is not radiologically seen, then the mammillary body, and then the cerebral peduncle. So a lot of action here, and we have built further on whatever we had learned previously. So this is a cis-sagittal sequence, which we do. And I will open, the chat is open, but can somebody tell me what is this, where I am pointing out this structure? On the chat, please. Pineal, very good. So what will be this? Which commissure is this? Posterior. Okay, very good. So what is this? You see this thing? There is a commissure here. Anterior. And this thin membrane where I'm just pointing out parallel to it. So this will be the Lamina terminalis, very good. And what is this? This thing, optic chiasma, very good. What is the name of this recess where I have drawn an arrow? So the recess, name the recess. Infundibular recess of the third ventricle. What is this cistern? Quadrigeminal, very good. So this is a case of hydrocephalus because of aqueduct stenosis, and you can see that there is a pineal cyst here, and there is some adhesions in the aqueduct, and you can see that this is the infundibular recess and how it is dilated, and you can see the upward bowing of corpus callosum also. So we are going through the ventricles here. So this is the cisterna magna, and the fourth ventricle is here. One thing which I want you to note is that this is the vermis, and it is causing this indentation posteriorly into the fourth ventricle. So we are coming superior to the level of the pons, and here we are. Now this is the interpeduncular cistern and the suprasellar cistern, and this thing is of course the ambient cistern, and this is quadrigeminal cistern. Quadrigeminal cistern is still there. We go all more superiorly. So this is thalamus, and this is the third ventricle. So now you know that this thing here is the anterior commissure, and this is the posterior commissure, which we saw on that sagittal. And these are those two internal cerebral veins which are draining the thalami and the basal ganglia. And in the exam, they will come with dural venous, sinus thrombosis. So you have to know this anatomy. So just a relevant coronal where you can see this foramen of Monro, which is draining into the third ventricle. And this is the third ventricle. So cisterns, this is a bit of a repetition, but there is a concept of, actually there are arachnoid, you don't have to know it, but this is just for your knowledge. You don't have to remember it for your exam. But within the CSF spaces, there are double layers of arachnoid, which gives, these are known as what we call Lilliquist membrane of cellar segment, and it divides suprasellar cistern and the interpeduncular cistern. Radiologically speaking, you don't have to remember that. So these are the same cisterns which we have already learned. And this is again the same thing which we have already learned. So these are the pre-medullary cistern, and then pre-pontine cistern with the basilar artery, and then suprasellar cistern, interpeduncular cistern, ambient, and the quadrigeminal cistern, the third ventricle here. And the third ventricle here, foramen of Monro. This is the internal cerebral veins in the quadrigeminal cistern. This is the cistern which was just underneath the splenium of the corpus callosum, somewhere here. And this is cistern of velum interpositum. This is just before it enters the quadrigeminal cistern. So look at these veins, and these are the exam veins I was talking about. Internal cerebral vein, thalamus. They are joining together. This is the pineal gland, and they will make the vein of Galen. So this thing here, you see this space here is the cistern of velum interpositum. So it is draining into the, or it is not draining, but it is in communication with the quadrigeminal cistern. And so this per se can come in your exam, where this is a repetition of what you have just learned on MR. Thalamus here, internal cerebral vein. This is with contrast, and you can see the anatomy very well if you know the concept. Now, this is an exam case. Because of a time factor, I am not going to give it for the Viva. But this is a classical FRCR 2B Viva case. Here you can see that the patient, 46-year-old, presented with headache and things like that to A&E. You can see that there is thrombosis, and anatomy tells you what has happened. This is internal cerebral. It is draining into the straight sinus, and even the superior sagittal sinus is thrombosed. So very rarely you will find it, but these come in the exam again and again when there is thrombosis of a cortical vein or a dural venous sinus. So a repetition of anatomy where you can see that this is the internal cerebral vein. You see this thing? This is internal cerebral vein. Both of them are draining together, making the vein of Galen. Now, vein of Galen combines with the inferior sagittal sinus to make this straight sinus. And in our case, these two are the internal cerebral vein. Vein of Galen will be here, and then the straight sinus, even the superior sagittal is thrombosed. When we did MRV of this patient, the patient did not cooperate, but practically all sinuses were gone. So this is interesting. This is a coronal sequence, and if you know your anatomy on an axial, you can stretch your imagination to make out the coronal. I will go back to just to consolidate. If you see here, this is the pineal gland. This is the vein here, right? To internal cerebral vein. This is the pineal gland. This thing here is the tectal plate, also known as quadrigeminal plate, also known as tectum, on which superior and inferior colliculus will be there. And this is tegmentum. If I go right and left, you can see the superior colliculus and inferior colliculus very well. So these are paired structure, two on right and two on left. Now I am showing you a coronal sequence. So change your brain to a coronal, and you can see that this is the internal cerebral vein, and this is the pineal gland. So this is the superior colliculus, and this is the inferior colliculus. And now the pineal gland is visible, and we are passing through the superior colliculus. These are the internal cerebral veins. And so basal ganglia and thalamus, I think we are going to just do them in 2 minutes because you already know it. But having said that, one point which I want you to remember is the caudate nucleus. Please remember that this is the shape of the caudate nucleus. So head of caudate nucleus is touching the frontal horn, but then it goes posteriorly and superiorly. So it will be touching the body. And at times you will see on MR infarctions which are next to the body. So somebody will say that this is periventricular infarction. Actually, that is not periventricular. It is by definition periventricular, but it means it is in the caudate nucleus. So as you see this structure goes, and it goes into the temporal lobe, and there is an amygdaloid body, which I will cover shortly. So I am going to skip these because we have already covered. The only point I want you to remember is about, so here, this is 3 Tesla MR. So the image is very good, but anatomy can be taught better here. This is head of caudate nucleus, head of caudate. So this is an axial slice and we are going superiorly. And you can see that here we are at the level of the body. And even here, the caudate is visible. Why? Because of this concept that it is C-shaped and it is still visible. So this is the body of caudate nucleus, which is next to the body of the lateral ventricle. So this point I want you to remember. Still visible here, isn't it? So it goes all the way up. Now, I will stop here, and after 5 minutes break, we will continue with the limbic system. And here I am going to teach you something new in the limbic system. So 5-minute break and we'll come back.